time, we shall go on to our first speaker, and we're going to actually start with the debate, which is going to set the whole fire to the whole webinar. And the debate would be started off by ANAGHA, who is going to tell us when she will go for Phakic IOLs, and she is going to be challenged by Dr. Naren Shetty, who would tell when he would say no to Phakic IOLs too. On to you, Anagha.
Yeah. Good evening, ma'am. Am I audible, ma'am?
Yeah.
Really sorry that my video is not working. Nevertheless, very good evening to everyone, and thank you so much at the outset for giving me an opportunity to speak on this. So my topic is when Phakic IOLs, no financial interest in any of the products. Myopia today is a public health crisis in waiting, and by 2050 it is predicted that nearly 50% of the world's population would be affected by myopia. And as the amount of myopia goes on increasing, the associated problems like cataracts, glaucoma, retinal detachments, and myopic macular degeneration will also increase. But today what we are going to focus is the dependence on glasses in all these patients and how we as ophthalmologists and as refractive surgeons can make their life easier, especially with lenticular-based refractive surgeries. So when we speak of phakic IOLs, what we need to do is a proper case selection, precise surgical technique, good counseling, and excellent post-operative care. So the first and foremost thing is to have a stable, perfect refraction. And when we go ahead and advise these patients about phakic IOL, we need to ensure that there is no overcorrection, especially in these very high myopes. Do not oversell, especially in the lower myopes. If LASIK is not possible, and if they are in their late 30s or early 40s, sometimes they'll be well off without doing any refractive surgery. The anterior chamber depth, most importantly, from the corneal endothelium and not the epithelium to the anterior lens capsule should be more than 2.8 millimeters. Now, when ICL was approved for phakic IOLs, the US FDA approval was from -3 to -15 diopters in 2005. And for astigmatism, it came into play by 2018 for 1 to 4 diopter cylinder. But the CE approval was from 0.5 to -18 diopters in 1997 and from 0.5 to 6 cylinder in 2003. So as we are going to discuss later on, we do a complete refractive surgery workup, including a topography, tomography. So when you want to decide about whether a patient should undergo phakic IOL or not, you look at the slit lamp, look at the anterior chamber configuration, especially if there is a family history of glaucoma. Ensure that the ocular surface is good. Do a lens thickness and a biometry completely, intraocular pressure measurement, anterior chamber angle, disc, and a specular biomicroscopy should show adequate endothelial cell count. So the basic thing is the patient should be at least 18 or 21 years. Many times we consider for phakic IOLs, the refraction should be stable over at least 1 year. And in all those patients where corneal-based surgeries like advanced surface ablation or LASIK is not possible, either because of the very high refractive error or a thin cornea with a low residual stromal bed, are indications for a phakic IOL. Yes, here we need to consider how we adhere to the law of thicknesses. Yes, today we consider around 300 microns for the residual stromal bed, and we need to reduce the risk of post-operative keratectasia. Might be keeping a post-operative corneal thickness of more than 400 microns would be a good idea. We also know that today a low corneal thickness itself has been found to be a risk factor. If you look at the Randleman scoring system, a very young patient with a low corneal thickness, especially less than 500, with a lower residual stromal bed, is going to be a very high risk for LASIK, and there we would decide to do a phakic IOL. Also, if it's a very flat cornea and if it's a high refractive error, making the cornea even more flat would lead to poor postoperative optics, glare, halos, and poor night vision, and here phakic IOL would be the better option. Now, for example, here we have a patient where in the right eye the -9, -1 cylinder and left eye is -5 with a borderline corneal thickness of around 500. So in the left eye, we went ahead and did a LASIK procedure. This is the post-operative corneal topography report, which shows the central myopic ablated area in the left eye. And in the right eye, we went ahead and did a phakic IOL. Now, this is a post-op total eye aberrometry of the same patient. And you can see in both the eyes, the refractive correction has been done. But if you also see the higher order aberrations are comparable, Whereas had we gone ahead and done a LASIK in the right eye, it would have caused a very high positive corneal spherical aberration and poor quality of vision in the right eye. We would also consider the percentage tissue altered. We all know that PTI is the flap thickness plus ablation depth divided by the central corneal thickness. And if it's more than 0.4 or 40%, it would be a high risk. And in all these cases, phakic IOL would be better. We need to stress that the retina has to be considered very, very strongly, and barrage laser done in case of lattice degenerations, any peripheral degenerations. If there are any changes in the OCT, this has to be considered. This is also, you can use it as a piggyback lens for pseudophakic residual refractive errors instead of a sulcoflex Rayner lens. Off-label indications include stable non-progressive keratoconus. More details will be there in few of the talks thereafter. And after keratoplasty, this picture shows how a phakic IOL has been used in a patient with intracorneal rings after the refraction and the topography has been stabilized. This was an article which showed how intraocular correction residual refractive error had good outcomes with a toric phakic IOL. So in any case where there is an anterior segment or a posterior segment ocular pathology, obviously we would not use a phakic IOL. Here we have compared the IPCL with the ICL, and the IPCL is relatively harder, so it's easier to handle. And it's more aspheric, and probably we don't need to rotate it because the IPCL is always aligned at 180 degrees in the toric case, whereas the ICL you need to rotate. So all you need to do is calculate the lens and have the lens power calculation and use the implantation orientation diagram. Most importantly, you need to counsel these patients regarding realistic expectations, explain the procedure, how different it is from LASIK, potential complications, especially of cataract, raised intraocular pressure, and in the presbyopic age group, explain to them the need for near vision correction or the option of presbyopic phakic IOLs. So these options need to be discussed with these patients. In our experience, we have found right from -2.5 to more than 20 diopters, excellent results. We evaluate them first day, 1 week, 1 month, 3 months, 6 months, yearly post-op with UCVA, BCVA, IOP, Walt, lens, retina, and the higher order aberrations. We have found that no patient actually lost lines, no significant IOP rise or cataract as a post-operative complication. So finally, to summarize, the most important advantages is a better quality of vision as there is no significant induced higher order aberrations, a small corneal incision which actually does not induce any astigmatism. As the corneal tissue is not removed, there is no risk of ectasia. It's closer to the nodal point, and hence there is a gain in the retinal size image, greater effective optical zone. It is a reversible procedure unlike LASIK, and there is no fixation into the tissues. So it's an excellent tool, but you need to do a detailed preoperative workup, precise surgical technique, close postoperative monitoring to get excellent results and happy patients. So finally, refractive surgery, especially phakic IOLs, is about care, more care, and even more care. Thank you so much for your kind attention. Thank you.
Thanks, Anagha. That was a succinct